Okay, let's unpack this.
Let's do it.
We're doing a deep dive into diabetes mellitus, but today we are getting super specific. We're talking type 1 diabetes, T1D.
Right.
And for anyone listening who is trying to really get the clinical flow, from the absolute crisis moment to long-term management, this is your shortcut. We're just cutting to the chase based on the source material.
That's the mission.
Yeah.
We want to quickly get the main differences between type 1 and type 2, and maybe even more important, the step-by-step clinical path you have to follow.
Especially that split between a stable patient versus someone in a life-threatening emergency.
Exactly.
So we have to start with the basics, because if you don't get the mechanism, none of this makes sense. Diabetes, at its core, just means there's too much sugar in the blood.
Oh.
Hyperglycemia.
Yep, the tissue cells just can't absorb it. And the key that's supposed to unlock the door for that sugar to get in is, of course, insulin.
The gatekeeper molecule.
It's a total powerhouse hormone. It's made by the pancreatic islet beta cells. And you can think of it as the body's ultimate resource manager. It's not just about glucose.
Oh, right.
It helps your body take up and store everything: glucose, amino acids, triglycerides. It stimulates all these essential processes like glycolysis, protein synthesis. It tells the body, okay, fuel's here, store it.
And the whole reason we have type 1 and type 2 diabetes is because something goes wrong with that system, with that gatekeeper.
That is the critical distinction. In type 1 diabetes, it's basically an autoimmune disaster. The body's own immune system gets confused.
It attacks itself.
It attacks and destroys those insulin-producing beta cells, so the factory's just gone, which leads to a severe absolute insulin deficiency. You have nothing to manage the fuel.
So that patient has to get insulin. Their body literally can't make it. How's that different from type 2?
Type 2 is more a story of resistance and exhaustion. First, the body's cells, they start to ignore the insulin. They become resistant. So the pancreas works overtime, pumping out more and more insulin to compensate.
Yeah.
But eventually, those beta cells just get worn out. They can't keep up. So it's a mix of resistance and a relative deficiency, not a total one.
So T1D is sudden destruction. T2D is a long, slow failure.
You got it.
Okay, let's talk urgency. This is where it gets really interesting. A clinician sees a patient, they suspect T1D. The first thought isn't, let's diagnose, it's what?
It's, are they going to crash?
Yeah.
The absolute first step, if you even suspect they're unstable, is the ABCDE assessment.
Airway, breathing, circulation.
Right. If they're confused, struggling to breathe, you might need to intubate to secure the airway. Then you get IV access immediately, start 4V fluids if they're hypotensive, and get them on continuous monitors. That part is non-negotiable.
And this is all because unchecked hyperglycemia can lead to these acute life-threatening states. We hear the terms DKA and HHS all the time.
Diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state, HHS.
DKA is the classic for type 1, right?
Far more common in T1D, yes. HHS is more typical for type 2. But clinically, when they first present, they can look scarily similar.
So what does that look like?
They're just wiped out. Fatigue, headache, that classic dry mouth, extreme thirst polydipsia, and urinating constantly, polyuria. They can be confused, even somnolent, so you might need to get the history from a family member.
And on the physical exam?
You're looking for the signs of shock. A high heart rate, that's tachycardia, rapid breathing, tachypnea, low blood pressure, hypotension, and just really dry mucous membranes. They are profoundly dehydrated.
So you have these two states, they look similar, but the chemistry underneath is totally different. This is where the labs are so cool. How do they instantly tell you DKA from HHS?
This is the real high-yield stuff. You run a point-of-care glucose, serum osmolality, a BMP, and you look for ketones in the urine. Plus, you'll want an ABG or a VBG to check their acid-base status.
Okay, give us the numbers for HHS first. What defines it?
HHS is all about massive, massive glucose elevation. We're talking often over 600. And critically, a very high serum osmolality, usually above 320. Their blood is just incredibly concentrated from all that sugar.
Wow. And DKA, the sugar isn't quite that high, is it?
No, usually it's lower, often above 250, but not in that 600 range. The key difference is the mechanism. In HHS, the person usually still has just a tiny bit of insulin floating around.
Just enough to do what?
Just enough to prevent massive fat breakdown, a process called lipolysis, so they don't typically form ketones. But in DKA, which is classic for T1D, there's zero insulin.
So with no insulin, the body can't use sugar for fuel. What does it do instead?
It panics. It starts desperately burning fat for fuel, and that process, lipolysis, produces huge amounts of acidic byproducts called ketone bodies.
And that's the K and the A in DKA, ketoacidosis.
Exactly. What defines DKA is the ketones and, crucially, an elevated anion gap metabolic acidosis. The body is literally being poisoned by acid. You'll see low bicarbonate on the blood gas and that high anion gap. That's the classic profile.
Okay, that makes the distinction crystal clear. DKA is about acid, HHS is about extreme dehydration.
They are different problems, but they do share some findings. In both, you'll see labs that reflect that dehydration, like hyponatremia, weird potassium levels, and high BUN and creatinine, which shows the kidneys are under stress.
And I assume A1C would be high in both if it was undiagnosed.
Oh, for sure.
So once you've stabilized them and you know if it's DKA or HHS, what's the immediate treatment?
It is a critical balancing act. Step 1 is aggressive IV fluid. Just pour it in to fight the dehydration. Step 2 is electrolyte repletion, and you have to be so careful with potassium.
Why potassium specifically?
Well, the high sugar and the acid drive potassium out of the cells into the blood, so it might look normal or even high at first. But the second you start the insulin drip, which is step 3, that insulin drives the potassium back into the cells.
And their blood potassium can plummet.
Dangerously low.
Yeah.
Potentially fatal hypokalemia. So you have to watch it like a hawk and replace it before or during the insulin infusion. And then, finally, you have to find out what pushed them into this crisis.
The underlying trigger.
Absolutely. It's often an infection like a UTI or pneumonia. You have to treat that cause or they'll just spiral right back into crisis.
Whew. Okay, so that was the high-stakes, life-or-death scenario. Let's shift back to the person who walks into a clinic. They're stable, not acutely sick, but you suspect diabetes.
Right. You've done your ABCDE assessment, and they're fine. Now you can take a breath and do a proper workup.
What does that history sound like?
You're asking about those same classic symptoms, just maybe less severe. Unintentional weight loss, the polyuria and polytipsia, that's the excessive urination and thirst, and sometimes blurred vision.
And because T1D is autoimmune.
You dig into that family history. You asked about other autoimmune issues like thyroid disease or celiac disease. It's all about pattern recognition.
What about the physical exam? What clues might you find?
Honestly, often not much if they're stable. Maybe some dry mucous membranes from chronic dehydration, or you might see oral thrush, a fungal infection that loves high-sugar environments.
Okay, so then we get to the definitive labs. We need to measure their sugar levels, right?
Correct. You'll order a hemoglobin A1C, a fasting blood glucose, and maybe a 2-hour oral glucose tolerance test, the OGTT, if things are still a bit unclear.
The source material gives us really specific cutoffs here, which are the backbone of all this. Let's start with prediabetes.
Prediabetes is that warning zone. It's an A1C between 5.7 and 6.5%, or a fasting glucose between 100 and 126.
And then the jump to a full-blown diagnosis of diabetes mellitus requires crossing those lines.
Correct. You officially have diabetes if any one of these is true. Your A1C is 6.5 or higher, your fasting glucose is 126 or higher, or that 2-hour OGTT is 200 or higher.
Or a random glucose test, right?
Right, a random glucose of 200 or more, especially if you have symptoms. That pretty much seals the deal.
So once you've confirmed diabetes, now you have to figure out which type it is. And this is where you bring in those more specialized tests.
This is where we pull out the big guns, the GAD65 antibodies, islet cell antibodies, and C-peptide levels. This is how we prove the factory has been destroyed.
Let's talk about C-peptide for a second. Why is that so useful? Why not just measure insulin?
Great question. Because C-peptide is a byproduct. It's released in a perfect 1-to-1 ratio when the pancreas makes its own insulin. So it's a perfect marker for endogenous insulin production. It tells you exactly how much your own body is making.
Not how much you might be injecting.
Exactly. So if you're T1D, your immune system has wrecked the beta cells. Your C-peptide level will be super low or even undetectable.
So, to confirm T1D, you need two things. The positive antibodies, proving the autoimmune attack.
Right, like GAD65.
And the low C-peptide, proving the factory is offline.
Precisely. T2D, on the other hand, would have negative antibodies, and the C-peptide would be normal or maybe even high because the pancreas is still trying so hard.
And since T1D is an autoimmune condition, especially in kids, should you be looking for other problems?
100%. This is a critical clinical pearl. If you confirm T1D, you have to have a high suspicion for other autoimmune conditions. You should screen them for Addison disease, celiac disease, and hypothyroidism. They often travel in packs.
Okay, so the diagnosis is confirmed. T1D. There's no ambiguity here. It's insulin for life. How do you even start?
The initial dosing is usually calculated based on weight, something like 0.3 to 0.7 units per kilogram per day. But the real art, and what the patient has to master, is the 50-50 split.
The basal bolus split. This is so important.
It's everything. Think of it like a security system for your metabolism. Basal insulin is the long-acting kind. It's about half your total daily dose, and it provides this constant background coverage. It's the firewall that keeps your glucose stable when you're sleeping or between meals.
And the bolus.
The bolus is the short-acting targeted dose. It's the other 50%. You use it for two things: to cover the carbs in your meals and snacks, and to make corrections if your blood sugar is too high.
That sounds like a full-time job. The carb counting alone.
It is, and that's why self-management education is the most important pillar of treatment. They need to learn how to give themselves insulin, how to check their levels, and how to spot and treat both highs and lows.
They need a target range to aim for, right?
Yep, generally between 70 and 180. And a specialized dietitian is absolutely vital. They help figure out those carb ratios and teach the patient how to adjust their doses for things like exercise or being sick or stress. It's never static.
And technology is really changing the game here, isn't it?
Oh, it's a game changer. Continuous glucose monitors, CGMs, they give you data around the clock without all the finger sticks. And then you have insulin pumps, which are wearable devices, providing a continuous infusion.
And some of them talk to each other now.
The most advanced ones do. They create these hybrid closed-loop systems, an artificial pancreas, where the CGM tells the pump to automatically adjust the insulin based on where your glucose is heading. It's incredible.
So once a patient is on this regimen, there's a follow-up protocol, right? You don't just send them on their way.
No way. We recheck their A1C at 3 months. That's the first major report card. If it's below 7%, great. That's an adequate response. We continue the plan and keep checking.
And if it's not? If it's 7 or higher?
That's an inadequate response. We need to adjust the regimen immediately to prevent those awful long-term complications.
Which is why annual screening is mandatory.
Every single year. You have to screen for diabetic retinopathy, which can cause blindness, neuropathy, which is nerve damage, and nephropathy, which is kidney damage. You have to catch these things early.
So let's bring this all together. What does this all mean? We started with that core idea. T1D is an autoimmune attack on the beta cells.
Right. Then we walk through that critical split, stabilizing the crashing patient in DKA or HHS, using the ABCDEs, versus the calm diagnostic path for a stable patient.
Using those hard cutoffs for A1C and fasting glucose, and then confirming the T1D diagnosis with antibodies and a low C-peptide.
And that diagnosis kicks off a lifetime of management. That 50-50 basal bolus insulin split, supported by education, technology, and just constant vigilant screening for complications.
It's a journey that is just defined by numbers and thresholds.
It really is. And, if we connect this to the bigger picture, the source material shows us just how tiny that window is between being okay and having a diagnosis. The jump from prediabetes to full-blown diabetes can be 0.1% on an A1C.
Going from 6.4 to 6.5?
Exactly. And that raises a really important question, especially for those at risk for type 2. Given that we can see this path so clearly, how transformative could it be if we got really aggressive with lifestyle changes before anyone ever crosses that official line? It's a powerful thing to think about.